Hi, my name is Anna Goldman, and I am an assistant professor at Boston University School of Medicine and Boston Medical Center. I'd like to thank SGIM for giving me the opportunity to present this talk despite the challenging circumstances. Today I'm going to speak to you about a project looking at the use of income thresholds for health insurance eligibility used by the Affordable Care Act and the impacts these have on the stability of health insurance coverage. I collaborated on this work with Sarah Gordon at BU School of Public Health, and I have no disclosures. As many of you know, the ACA created two major insurance programs, the Medicaid expansion and marketplace coverage, both of which started in 2014. The eligibility for these programs entirely depends on where your income falls in relation to the federal poverty level. To give you a sense, in 2014, 100% of the federal poverty level for a family of three was just under $20,000 per year. The Medicaid expansion allowed people living in expansion states with incomes up to 138% of poverty to obtain Medicaid. In 2014, 138% of poverty for a family of three was just over $27,000. So far, 37 states have expanded Medicaid. The ACA also established marketplace insurance, the cost of which is subsidized for families with incomes above 138% of poverty and up to 400% of poverty. So this 138% of poverty threshold is an important thing to remember during this talk. It's the threshold where somebody crosses from Medicaid eligibility to marketplace or vice versa. Several studies that were published prior to the ACA warned that very high numbers of adults would be crossing that 138% threshold, and that this would lead millions of people to be flip-flopping between Medicaid and marketplace coverage. This first study predicted 50% of poor and near poor adults would cross that threshold each year, so either moving from above to below or below to above, and that would be leading to massive numbers of people, millions even, to be forced to switch coverage types. Similarly, the study at the bottom of the slide from the New England Journal predicted about 56% of adults per year would be crossing that threshold. So why does coverage instability matter? Evidence has shown that coverage instability, both the kind where a person switches insurance types and the kind where a person experiences a coverage gap, has a range of negative effects, including delays in care, greater use of the emergency department and inpatient care, refilling prescriptions less often, and accessing less preventative care. So this is an issue that truly impacts patients, and therefore it's quite relevant for policymakers to think about and for us to think about. With that in mind, we had three objectives with this study. First, how often are people crossing the income threshold? We wanted to see if the pre-ACA predictions were borne out. Second, we wanted to study the extent to which threshold crossing creates a source of coverage instability. And lastly, we wanted to ascertain how often people are switching between Medicaid and marketplace coverage. To study this, we used the Medical Expenditure Panel Survey, or MEPS, which is a nationally representative data set containing about 15,000 households per year. We used the years 2009 to 2017 and used the 2-year longitudinal data sets that are available in MEPS. We included non-elderly adults, and we restricted to adults whose household incomes were within 30 percentage points of that 138% threshold. So our study population had incomes between 108 and 168% of the federal poverty level. And we did this to home in on the group that would be most at risk for coverage instability. And I just want to pause to say that even though we chose to focus specifically on that 138% threshold in this study, we're more broadly interested in the use of income thresholds for health insurance eligibility in general. So here's a graphic of the overlapping survey design of the MEPS. We used 8 cohorts that were surveyed between 2009 and 2017. The survey follows study subjects for 2 years, and the cohorts overlap. We stacked the first 4 groups to form the pre-ACA cohort and the last 4 to make the post-ACA cohort. To study rates of threshold crossing, we used annual data on household income. We defined someone as a threshold crosser if their household income in the first year was under 138 and then rose above the threshold in the second year, or vice versa. Then, to study the question of whether threshold crossers were experiencing more coverage disruption, we used monthly data available in the MEPS on health insurance coverage and coverage type, including Medicaid, marketplace, and employer-sponsored coverage. We measured all outcomes related to insurance coverage in year 2 of the longitudinal data set. And we chose to do this so that we could follow people over time and see what happened in terms of coverage changes to threshold crossers versus non-crossers. So I'll briefly define our outcomes. A coverage disruption was defined as moving from coverage in 1 month to either different coverage, a different type of coverage, or no coverage in the next consecutive month. And a coverage loss was moving from coverage to no coverage in any 2 consecutive months. And this gap could represent either a short-term or a longer-term period of uninsurance. And now to describe the analyses we did, we calculated survey-weighted frequencies of all of our major outcomes to determine how often these things were happening in our study population. And to test whether threshold crossing was associated with higher rates of coverage disruption and loss, we performed logistic regression in which the predictor was whether or not the individual was a threshold crosser. And then we calculated odds ratios to compare the odds of coverage disruption and coverage loss in threshold crossers versus those who did not cross during the post-ACA period. We adjusted for the covariates you see listed on the slide. And we also did a difference in difference analysis as a sensitivity analysis in which we added the pre-ACA data. Moving on to results, here are the characteristics of our study sample. There was a total of 10,583 subjects in the sample, with about 4,200 that crossed the threshold and 6,300 that did not. The threshold crossing group was quite similar to the non-crossing group, except for the threshold crossers were less likely to be white. Here are the results showing the prevalence of threshold crossing in our study population. You can see the pre-ACA results in blue and post-ACA in green. These first columns show the total rate of threshold crossing, which was about 40% in both time periods. It went up very slightly in the post-ACA period. About 25% of this was due to income rising from below 138 to above, and about 15% was due to income dropping from above the threshold to below. And overall, the rates were quite similar in the pre and post period, but they did rise slightly in the post-ACA period. And here are the results showing rates of coverage disruption and coverage loss. For reference, I'm again showing you the rate of threshold crossing, which was about 40% in both time periods. These are the same bars that were on the previous slide. However, when we look at rate of coverage disruption, the rate is comparatively lower. It was 11.3% in the pre-ACA period, and it increased to 15.5% in the post-ACA period. Rates of coverage loss were also relatively low and went up from 8.5% in the pre-ACA period to 10.9% in the post-ACA period. Here I'm presenting the results of the logistic regression. Among those whose incomes did not cross the threshold during the study period, 15.9% experienced a coverage disruption and 11.4% experienced a coverage loss. Compared to this group of non-crossers, those who did cross appeared to have a slightly higher odds of both coverage disruption and coverage loss, but neither reached significance. And I'll just mention that the sensitivity analysis we did, the difference in difference where we added the pre-ACA data, yielded very similar results, similar in magnitude and also not significant. Here are the rates of switching between Medicaid and Marketplace coverage. You see that the rates of switching are quite low, less than 1% for each type of switching. Remember that both of the articles I cited at the beginning predicted that millions of people would be moving back and forth between Medicaid and Marketplace insurance. But we did not see that happening. We estimated instead that about 300,000 to 400,000 people were experiencing a Medicaid Marketplace coverage switch per year. We also did do a sensitivity analysis where we varied the width of the income brackets around that 138% threshold that defined our study population. So our study used 30 points above and below the threshold. We reran all of our analyses with the group whose incomes were 20 points above and below and 40 points above and below, and the results were almost entirely unchanged. To add to the robustness of this analysis, we have one more future analysis planned. This will be a difference in difference analysis in which we examine our outcomes of coverage disruption and coverage loss, but by Medicaid expansion status of the state where the person lived. And here we will restrict our study population to those with incomes between 100 and 200% of poverty. In expansion states, adults in this income range were exposed to that 138% income threshold. However, no threshold exists in non-expansion states because in those states, marketplace subsidies are available to anyone with incomes above 100% of poverty. So for that reason, the non-expansion states are an excellent control condition where there is no threshold. However, the state identifiers in MEPS are restricted and they can only be accessed at Census Bureau data centers. I do have access to these state identifiers and I've worked with them in the past, but unfortunately the data center has been shut down during the pandemic, and so I will need to work on this when it reopens. So what conclusions can we draw from this study? First of all, the frequency of threshold crossing in a 2-year period is about 40% in our near threshold study population. This was roughly consistent with the pre-ACA predictions. Both of the pre-ACA estimates that I discussed at the beginning of the talk were closer to 50%. It's very likely that that slightly higher magnitude finding in their study compared to ours is explained by the fact that they used monthly income data and we used annual, so they had more data points to work with. However, the most important thing that we found is that this high frequency of threshold crossing does not seem to translate to high rates of coverage disruption. And lastly, we found that the rates of switching between Medicaid and marketplace coverage were much lower than predicted, with about 300,000 to 400,000 people switching per year. So why didn't the high rate of threshold crossing translate to high rates of coverage disruption? The most likely reason is that the ACA included a new stipulation about Medicaid recertification. So this was that states cannot require Medicaid enrollees to submit income data to prove Medicaid eligibility more than once a year. This rule appears to have been very effective in preventing a lot of coverage switching among people who cross the income threshold. States still do have the power to disenroll people from coverage if they find out through other sources of data, like state income tax data, that a person is no longer eligible, but it seems that that's not happening too often. States also do have the option to adopt 12-month continuous eligibility, which is slightly different. So that means that if somebody qualifies for Medicaid in a given month, they can keep their Medicaid for a full 12 months, even if the state finds out through other means, like tax data, that their income rose. So far, only Montana and New York have adopted this policy, so it probably isn't widespread enough to account for our findings. And lastly, the income data in the MEPS may be subject to error, even though the survey does attempt to verify income data as much as possible. I'd like to acknowledge some limitations. The income data in the MEPS is annual, so we only had 2 data points for year 1 and year 2. As I mentioned, those pre-ACA studies used monthly income data from the Census Bureau. Unfortunately, we couldn't use that data because the Census Bureau redesigned their data collection process in 2014 in a way that makes it difficult to combine pre and post ACA data. Second, we were restricted to a single year of follow-up, so there may in fact be more Medicaid and marketplace churning if we had a longer follow-up period. And lastly, our relatively small sample size may have limited our ability to detect significant results in our logistic regression analysis. So what are the policy implications? Our original motivation for doing this project was really to ask the question, does a patchwork healthcare system harm low-income Americans by frequently disrupting coverage? The ACA created a system where coverage is really pieced together, and if your income changes, you're kind of bouncing between different coverage, and that ultimately might be harmful for patients. A single-payer system would entirely avoid that pitfall. The results of our study seem to suggest that actually this patchwork approach isn't causing any big problem. However, that's not the whole story. The real story is that the system is being held together by a thread. And that thread is the little-known stipulation in the ACA that I mentioned before, that state Medicaid programs can't ask people for their income information more than once a year. What if people were to start challenging this rule? Well, it turns out that opponents of Medicaid expansion have recently started raising this issue. There was a congressional hearing about this last October, and arguments have been published recently in the Wall Street Journal and by the Galen Institute claiming that lots of people are receiving Medicaid who have incomes above that 138% threshold. And also, if states decide to get more proactive about this issue, they can start looking at other internal data sources like income tax data to check on people's income and kick them out of their coverage if their income has crossed the threshold. So in the end, I would say that the most important takeaway from this talk is that if this part of the ACA is eventually struck down, or if states become more proactive about looking at other data sources, we could have a big problem on our hands with 40 to 50% of the near poor population getting kicked off their coverage on a regular basis. A single-payer system such as Medicare for All could avoid this problem entirely. And with that, I'd like to thank you for listening, and I'd be delighted to answer any questions by email.